This represents 50 million people worldwide diagnosed with epilepsy, 1% of the human population. But here lies a severe clinical paradox. Up to 30% of patients referred for drug-resistant seizures do not actually have epilepsy. The immediate clinical consequence for this group is severe. They face an average diagnostic delay of 7 to 10 years, enduring increasing doses of medications that provide zero relief, compounding their suffering with heavy side effects. Untangling this overlap requires the taxonomy frameworks established by the International League Against Epilepsy. Clinicians must use this system to rigorously categorize seizure types based on their underlying etiologies. The core necessity here is drawing a strict clinical line between true epileptic seizures and a specific mimic known as psychogenic non-epileptic seizures, or PNES. When the root cause is misidentified, the use of anti-seizure drugs offers no therapeutic benefit, exposing the patient to the direct risks of iatrogenic harm, completely without addressing the actual source of the events. Under normal conditions, healthy neuronal network function relies entirely on a precise equilibrium. The brain maintains a strict balance between cellular excitation and inhibition. This graphic shows primary neurotransmitter receptors in the synaptic cleft. Blue GABA-A channels allow chloroid in, inhibiting the cell. Red glutamate channels excite it. An epileptic seizure fails this balance. Excess glutamate or deficient GABA causes massive hypersynchronous neuronal bursting. Specific cellular defects drive this imbalance, mutations in voltage-gated ion channels, or rapid downregulation of GABA receptors. The hallmark is the paroxysmal depolarization shift, a massive, prolonged voltage spike followed by a rapid burst of action potentials. This isolated cellular defect does not stay isolated. The pathological synchrony propagates rapidly, recruiting wider neuronal networks via synaptic pathways and electrical gap junctions. True epileptic seizures are measurable hardware failures in the brain's cellular electrophysiology. Anti-seizure medications are precisely engineered molecular tools designed to intercept these specific hardware failures. However, these drugs have an absolute limitation. They forcefully suppress hypersynchronous firing, but they do not alter or cure the underlying epileptogenic process itself. This matrix maps specific drug classes by their distinct mechanisms of action. Sodium channel blockers physically lock into the inactive state, preventing rapid, repetitive firing. SV2A ligands throttle excitatory glutamate release into the cleft. Specific epilepsy syndromes demand exact pharmacological matches. Treating absent seizures requires ethosuxinimide because it exclusively targets the T-type calcium channels, acting as thalamic pacemakers. Deploying the wrong targeted mechanism violates strict clinical contraindications. Giving a sodium blocker to a patient with Dravet syndrome will dramatically worsen their seizures. Because anti-seizure medications are precision-engineered to fix specific electrical defects, they are entirely useless if the patient's seizure does not originate from an electrical anomaly. This brings us back to the biopsychosocial 3P model explains severe motor outputs without an electrical storm. Predisposing factors, like trauma, disrupt limbic motor connectivity. Precipitating factors, like acute stress, trigger the dissociation. Perpetuating factors, like misdiagnosis and inappropriate anti-seizure treatments, drive the chronic cycle. PNES is a software processing error. It is a network dissociation, making it entirely immune to the hardware effects of anti-seizure medications. Relying purely on visual observation to separate epileptic from functional seizures results in massive misdiagnosis rates. Certain physical markers point heavily toward true epilepsy. The patient's eyes are usually open, they may exhibit lateral tongue biting, and they experience prolonged confusion after the event ceases. PNES events present differently. The convulsions often last longer than 5 minutes. The eyes are tightly closed, the patient may exhibit rhythmic pelvic thrusting, and they return to their baseline awareness rapidly. But clinical observation is not enough. The absolute diagnostic gold standard required to break the tie is video EEG monitoring. This split-screen readout definitively maps physical clinical manifestations against the patient's real-time cortical electrical activity. The epileptic VEG signature is defined by a physical convulsion occurring in synchronization with hypersynchronous spike and wave discharges on the EEG readout. The PNES signature reveals the mimic. A severe physical convulsion occurs, but the brain's baseline electrical rhythm remains completely normal, displaying only minor physical movement artifacts. This establishes a strict diagnostic rule. If the ictal EEG remains completely normal during a motor convulsion lasting longer than 90 seconds, the event is definitively PNES. Upon confirming PNES, the clinical protocol shifts radically. The immediate priority is the supervised withdrawal of all inappropriate toxic anti-seizure medications. The actual primary treatment for PNES is multidisciplinary psychotherapy, relying heavily on trauma-focused cognitive behavioral therapy to rebuild emotion regulation. In modern neurology, treating a seizure relies entirely on mapping the exact phenotype to the correct underlying network. The defect must be proven before the drug is ever deployed.